Hi everyone, this is Neil Wright here, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the iClearScope endoscope. And here we have a patient who attends probably every 12 to 18 months and they suffer from superficial otitis externa. What I mean by that is otitis externa is an umbrella term given to infection or inflammation of the outer ear. And the outer ear is composed of the pinna or the auricle, which is the fleshy cartilage that we have on either side of our heads that resemble a satellite dish, the ear canal, and also the outermost layer of the eardrum. So the eardrum is 3-ply thick, and the outermost layer, which is actually made up of epidermal skin, which also lines the inner 2/3 of the ear canal. That's the outer ear. So if you've got an infection or inflammation of that region, you call it otitis externa. If it's actually the outer layer of the eardrum or the eardrum itself, you can sometimes, another name for that is myringitis. You can get granular myringitis, for example, or bulbous myringitis. And then you get the term superficial, it's more kind of the outer layer of the skin. So in this case, this patient hasn't really got any visible edema or discharge. So edema, swelling, or even really any erythema or inflammation. It's just really dry, flaky skin. And again, they've visited the doctors, and it's just something that it's just chronic for this patient. So it's just it doesn't really cause them much of an issue. They get a slight itch now and again, which they use some acetic acid spray over the counter from the pharmacy to help with, and it does help. And they also do use some medical grade olive oil from time to time to help moisturize the skin. Their wax is a bit of a funny one. Laterally it's pretty dry and crusted, but here it's a bit more soft and mushy. I did put some oil in. I think I've used the ear hook correct already, and here's the pick, but the pick just really cut through. It's not the right consistency. For the pick, it's really, so if the wax here that I'm removing, if the whole plug was this consistency, then the pick will work really, really well. Now, because we're working right near the entrance where all the hairs are, you can see, and we have to have the endoscope there because otherwise we can't see what we're doing. Some of the hairs are just kind of, because I put the oil in as well, we did attempt to dry them out as well, but they kind of smear the lens ever so slightly. But once we get this out, we'll get a better view. It's a thick layer of skin here, and it's also attached to the ear canal. You can see the skin because it's a lighter, glossier complexion. So to have a real chance of removing this, we need to peel this away. And it's also attached posteriorly. And a bit later on in the procedure, I'm going to use a correct against the back part of the ear canal, and you'll see this skin. It was lining the majority of the posterior canal wall, so the back part of the ear canal. So I'm just trying to get a suction grip, and there's a little wriggle movements. And I'm also tugging at it just to kind of separate that skin. This is where I find wax is most commonly adhered to the ear canal, at the back lateral aspect. So I'm just getting a bit higher up, see if this piece comes away, because I've kind of loosened the area underneath, and sometimes you can just get flakes of wax that comes away, but I think we're making some progress there. But where I am now with the suction probe, it's really dry. They have got a very bendy ear canal as well. So our ears are not, unfortunately, straight cylindrical tubes. In fact, it's good that they're a bit bendy because it helps to protect your eardrum. If you have a foreign object that enters your ear, it makes it less likely for that foreign object to come in direct contact with the eardrum because it has to navigate the bends. But if you've got an extremely narrow, a bendy ear canal, and narrow, you're a bit more prone to wax accumulation because the wax is trying to migrate outwards. And the way it does that, we have a natural conveyor belt in our ear, and that's the skin that lines the outermost layer of the skin, the epidermis layer. It migrates from the deepest region of the ear canal where new skin is formed, and actually new skin is formed at the center of the eardrum where the umbo is. We call that the progenitor site. And this skin that's secreted and formed then starts to migrate around 3 millimeters a month. I mean, there is variability in that between individuals and also between ears in the same patient. And as that skin migrates from the deepest region of the ear canal to the entrance, any wax sitting on the surface is also naturally transported out the ear. But when you've got, it's a bit like a river, if you've got kind of a meandering river, it kind of deposits all the heavy loads on the inside because it slows down the speed of the river is slower. I think it is, isn't it? I hope it is. So I'm giving you wrong information. But I think with a river, as the water is travelling on the inside, because it's travelling at a slower rate, all the heavy rocks and deposits it settles, whereas the water on the outside of the bend, again, hopefully I'm correct in that, it travels faster. So any heavy rocks, deposits, is also transported away. Similar with the ear in a way. When you've got a bendy ear, it's going to migrate a bit slower in those regions. And the ear's producing wax quicker than the ear can naturally expel it. So here's when I'm just using the correct posteriorly, and I just separated that skin. I was hoping that this will come out in one plug. Can't get any deeper than that at this stage with the correct, because you can see it's really deep at the top and it's right up against the roof of the ear canal. So I don't want to make it uncomfortable, so I decided just to cut this layer away. And what am I going to use next? I think I might use suction. There we are. Because I've separated this plug, it'll suction a bit better now. So again, this is some skin actually. It's a tail of skin. I'm just going to remove that. And I'm just trying to get the tip of this plug. And now that I've got a decent suction grip, I'm going to just kind of wriggle this out of the ear, navigating the bends of the ear to reduce any friction and resistance. So we need to tuck this plug inside that first bend. So I've just gone to the back part of it and I'm bringing it right to left. And as I am and coming away, there we are. Now already I can see the eardrum and it's severely retracted. It's buckled inwards. I'll explain again. I explained it in the other video I'm going to upload today on my other YouTube channel, Clear Wax, where I use the wax scope. But you can see at the top part of that eardrum, there's a pocket there. It's sucked in out. Fortunately, it's clear of any debris or dead skin. And the reason why this patient's eardrum is sucked in, I think this one was also, but not as much as their left side. They've got chronic eustachian tube dysfunction. So the eustachian tube is a narrow tube that connects the middle ear cavity, which is the space behind the eardrum, to the back of the nose. And the function of the eustachian tube, it has several. The first one is it's the pressure equalizer in the middle ear. We want the middle ear pressure, the air pressure behind the eardrum, to be equal or thereabouts to the air pressure in the ear canal. When the air pressure is equal or similar either side of the eardrum, that's when your eardrum is most mobile and therefore likely to vibrate in response to sound waves. It also serves as a drainage pipe, so any fluid accumulation behind the eardrum, it can help it drain away. Has some other functions as well. So now the eustachian tube at normal resting state should be shut, and it typically opens momentarily when we swallow, yawn and chew, and during those moments is when the air pressure equalizes and fluid can drain out. But being closed most of the time, there's a reason for that. There's two reasons. It prevents you from hearing your voice in three different routes. So we already hear ourselves speak via both air conduction, where when you speak, your voice is projected out your mouth and it enters your ear canal and it hits the eardrum on the outside, and also through bone conduction. So but again, when we speak, it causes the skull and the three middle ear bones, the ossicles, to partially vibrate, and these vibrations stimulate the organ of hearing directly. But if your eustachian tube is permanently open, when you speak, you can also hear yourself through your nose. So your voice travels up your nose, travels up the eustachian tube and vibrates against the inside of the eardrum via the middle ear. In addition, your eustachian tube being typically closed most of the time helps prevent upper respiratory tract infections, any infection of the nasopharynx, travelling up the eustachian tube and then infecting the middle ear. And the eustachian tube being normally shut also prevents yourself from hearing and feeling yourself breathe. So there's a condition called patulous eustachian tube, and that's where the eustachian tube is more or less permanently open. And with patients who I treat with patulous eustachian tube, they can normally not only hear themselves speak, but more annoyingly for them, they can hear themselves breathe. So every time they inspire, air travels up the nose, it fills up the middle ear cavity because the eustachian tube is open, and it causes the eardrum to inflate because there's positive pressure behind the eardrum in the middle ear. And when they exhale, air escapes the middle ear and it causes the eardrum to flex inwards, so it gets sucked in. And patients with patulous eustachian tube, they can actually not only hear themselves breathe because the mere action of breathing is stimulating the eardrum, but they can feel their eardrum move as well. It can be really annoying for them. So a couple of my patients who suffer from patulous eustachian tube, to overcome that, they perform the Toynbee manoeuvre. And the Toynbee manoeuvre is the opposite almost to the Valsalva. So the Valsalva is something that probably most of us have performed in the past. So for example, when you descend on an aircraft and the air pressure in the cabin pushes your eardrum in, to kind of release the eardrum, pop it back out, we gently close our mouth, pinch our nose and blow into our nose. And because the air is trapped inside our nose and mouth, it travels up the nasal passage, up the eustachian tube, and it inflates the middle ear to pop the eardrum out. The Toynbee is almost the opposite. So when you close your mouth, pinch your nose and you swallow, and that causes the eustachian tube, the muscles where it connects to the back of the nose to contract. It opens up the eustachian tube and it helps air to escape. So patients with patulous eustachian tube, some of them at least, perform the Toynbee manoeuvre to retract the eardrum, to suck it in. And the reason for that is both the outer layer and the inner layer of the eardrum is somewhat sticky. So when they cause the eardrum to get sucked in, it attaches to the hammer bone. And that restricts the eardrum from vibrating and flexing and moving when they breathe. There is some treatments for patulous eustachian tubes. So I had a patient recently who I referred to my ENT colleague, Darish Rajali, and he put what we call a steri-strip on the eardrum to add additional weight. Previously, from what I've read, blue tack was attached to the eardrum just to add a bit of weight to the eardrum so it doesn't flex as much when you breathe. Other treatments are some kind of, you can get some nasal sprays that induce swelling at the back of the nose. I don't think they're that very effective from speaking to a few of my ENT colleagues. I think iodine-based nasal drops, and there's another one as well, can induce swelling at the back of the nose to kind of block up their eustachian tube. Some ENT inject fillers to bulk up the area of the eustachian tube where it connects to the back of the nose. So patients who are most prone to developing patulous eustachian tube are patients who suddenly lose a lot of weight. So the fatty tissue is no longer present where it connects to the back of the nose, so it causes it to stay permanently open. And also female patients who are pregnant, and quite often when they're due to give birth, and I think the reason for that is the body's preparing itself to give birth, obviously, so the muscles somewhat relax, and the muscles at the back of the nose where they surround the eustachian tube similarly less contract and loosen, and it causes eustachian tube to be open more. So again, you've got an attic retraction at the top, and that's because this patient's eustachian tube is permanently blocked. It's not opening when it should, so it's no air in the middle ear causing the eardrum to get sucked in. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon.